In Chapter 1, we discussed the architecture of the normal human genome. Here we build on that knowledge to discuss the genetic basis of human diseases. Genetic disorders are far more common than is widely appreciated. The lifetime frequency of genetic diseases is estimated to be 670 per 1,000. Furthermore, the genetic diseases encountered in medical practice represent only the tip of the iceberg. That is, those with less extreme genotypic errors that permit full embryonic development and live birth. It is estimated that 50% of spontaneous abortuses during the early months of gestation have a demonstrable chromosomal abnormality. There are, in addition, numerous smaller detectable errors in many other genetic lesions that are only now being recognized thanks to advances in DNA sequencing. About 1% of all newborn infants possess a gross chromosomal abnormality, and serious disease with a significant genetic component develops in approximately 5% of individuals younger than age 25 years. How many more mutations remain hidden? Before discussing specific aberrations that may cause genetic diseases, it is useful to note that human genetic disorders can be broadly classified into 3 categories. Disorders related to mutations in single genes with large effects. These mutations cause the disease or predispose to the disease and, with some exceptions like hemoglobinopathies, are typically not present in the normal population. Such mutations and their associated disorders are highly 141, 1 genetic 452 chapter disorders. Penetrant, meaning that the presence of the mutation is associated with the disease in a large proportion of individuals. Because these diseases are caused by single gene mutations, they usually follow the classic Mendelian pattern of inheritance and are also referred to as Mendelian disorders. A few important exceptions to this rule are noted later. Study of single genes and mutations with large effects has been extremely informative in medicine, since a great deal of what is known about several physiologic pathways, for example, cholesterol transport, chloride secretion, has been learned from analysis of single gene disorders. Although informative, these disorders are generally rare unless they are maintained in a population by strong selective forces, for example, sickle cell anemia in areas where malaria is endemic. Chapter 14. Chromosomal disorders. These arise from structural or numerical alteration in the autosomes and sex chromosomes. Like monogenic disease, they are uncommon but associated with high penetrance. Complex multigenic disorders. These are far more common than diseases in the previous 2 categories. They are caused by interactions between multiple variant forms of genes and environmental factors. Such variations in genes are common within the population and are also called polymorphisms. Each such variant gene confers a small increase in disease risk, and no single susceptibility gene is necessary or sufficient to produce the disease. It is only when several such polymorphisms are present in an individual that disease occurs, hence the term multigenic or polygenic. Thus, unlike mutant genes with large effects that are highly penetrant and give rise to Mendelian disorders, each polymorphism has a small effect and is of low penetrance. Since environmental interactions are important in the pathogenesis of these diseases, they are also called multifactorial disorders. In this category are some of the most common diseases that afflict humans, including atherosclerosis, diabetes mellitus, hypertension, and autoimmune diseases. Even normal traits such as height and weight are governed by polymorphisms in several genes. The following discussion describes mutations that affect single genes, which underlie Mendelian disorders, followed by transmission patterns and selected samples of single gene disorders. Mutations. A mutation is defined as a permanent change in the DNA. Mutations that affect germ cells are transmitted to the progeny and can give rise to inherited diseases. Mutations that arise in somatic cells understandably do not cause hereditary diseases but are important in the genesis of cancers and some congenital malformations. General principles relating to the effects of gene mutations follow. Point mutations within coding sequences. A point mutation is a change in which a single base is substituted with a different base. It may alter the code in a triplet of bases and lead to the replacement of one amino acid by another in the gene product. Because these mutations alter the meaning of the sequence of the encoded protein, they are often termed missense mutations. If the substituted amino acid is biochemically similar to the original, typically it causes little change in the function of the protein, and the mutation is called a conservative missense mutation. On the other hand, a non-conservative missense mutation replaces the normal amino acid with a biochemically different one. An excellent example of this type is the sickle mutation affecting the beta-globin chain of hemoglobin. Chapter 14. Here the nucleotide triplet CTC or GAG and mRNA, which encodes glutamic acid, is changed to CAC or GUG and mRNA, which encodes valine. This single amino acid substitution alters the physicochemical properties of hemoglobin, giving rise to sickle cell anemia. Besides producing an amino acid substitution, a point mutation may change an amino acid codon to a chain terminator or stop codon nonsense mutation. Taking again the example of beta-globin, a point mutation affecting the codon for glutamine CAG creates a stop codon UAG if U is substituted for CFIG 5.1. This change leads to premature termination of beta-globin gene translation, and the short peptide that is produced is rapidly degraded. The resulting deficiency of beta-globin chains can give rise to a severe form of anemia called beta-zero thalassemia. Chapter 14. Mutations within non-coding sequences. Deleterious effects may also result from mutations that do not involve the exons. Recall that transcription of DNA is initiated and regulated by promoter and enhancer sequences. Chapter 1. Point mutations or deletions involving these regulatory sequences may interfere with binding of transcription factors and thus lead to a marked reduction in or total lack of transcription. Such is the case in certain forms of hereditary anemias called thalassemias. Chapter 14. In addition, point mutations within introns may lead to defective splicing of intervening sequences. This, in turn, interferes with normal processing of the initial mRNA transcripts and results in a failure to form mature mRNA. Therefore, translation cannot take place, and the gene product is not synthesized. Deletions and insertions. Small deletions or insertions involving the coding sequence can have two possible effects on the encoded protein. If the number of base pairs involved is 3 or a multiple of 3, the reading frame will remain intact and an abnormal protein lacking. 38. THR. A CCC a G a GG. A CCU a G a GG. Beta 0 globin THR allele 38. Stop. Figure 5.1 nonsense mutation leading to premature chain termination. Partial mRNA sequence of the beta globin chain of hemoglobin showing codons for amino acids 38 to 40. A point mutation CU in codon 39 changes a glutamine GLN codon to a stop codon, and hence protein synthesis stops at amino acid 38. Normal beta globin allele 3940 GLN R. Genes in human diseases 143. Normal DNA allele phi, gly, val. TAC act TTT GGT GTT. ABO allele, LU, val. TTC, XC 500, CF, TAC. Mutation. If the number of effects for gaining one or more amino acids will be synthesized. Fig. 5.2. If the number of affected coding bases is not a multiple of 3, this will result in an alteration of the reading frame of the DNA strand, producing what is referred to as a frameshift mutation. Figs. 5.3 and 5.4. Typically, the result is the incorporation of a variable number of incorrect amino acids followed by truncation resulting from a premature stop codon. Alterations in protein, coding genes other than mutations. In addition to alterations in DNA sequence, coding genes also can undergo structural variations, such as copy number changes, amplifications or deletions, or translocations that result in aberrant gain or loss of protein function. As with mutations, structural changes may occur in the germline or be acquired in somatic tissues. In many instances, pathogenic germline alterations involve a contiguous portion of a chromosome rather than a single gene, such as in the 20-twac microdeletion syndrome, discussed later. With the widespread availability of next-generation sequencing NGS technology for assessing genome-wide DNA copy number variation at very high resolution, potentially pathogenic structural alterations have now been discovered in common disorders such as autism. Cancers often contain somatically acquired structural alterations, including amplifications, deletions, and translocations. The so-called Philadelphia chromosome, translocation T9, 22 between the BCR and ABL genes in chronic myeloid leukemia. Chapter 13, is a classic example. Alterations in non-coding RNAs. It is worth noting that in the past, the major focus of gene hunting was discovery of genes that encode proteins. We now know that a very large number of genes do not encode proteins but produce transcripts, so-called non-coding RNAs, ncRNAs, that serve important regulatory functions. Although many normal hexa allele, CTC, GTG, GT, XCCTT, JL, ABO allele, LU, val, valpro, LU, altered reading, frame, figure 5.3 single, base deletion at the ABO glycosyltransferase locus, leading to a frameshift mutation responsible for the O allele. From Thompson M.W. et al., Thompson and Thompson Genetics and Medicine, ed. 5, Philadelphia, 1991, W.B. Saunders, p. 134. Distinct families of ncRNAs exist. The two most important examples, small RNA molecules called microRNAs, miRNA, and long non-coding RNAs, lncRNAs, are discussed in Chapter 1. Trinucleotide, repeat mutations. Trinucleotide, repeat mutations belong to a special category of genetic anomaly. These mutations are characterized by amplification of a sequence of 3 nucleotides. Although the specific nucleotide sequence that undergoes amplification differs in various disorders, almost all affected sequences share the nucleotides guanine G and cytosine C. For example, in Fragile X syndrome FXS, prototypical of this category of disorders, there are 250 to 4,000 tandem repeats of the sequence CGG within the regulatory region of a gene called familial mental retardation 1 FM-ROM. In normal populations, the number of repeats is small, averaging 29. Such expansions of the trinucleotide sequences prevent normal expression of the FM-ROM gene, thus giving rise to intellectual disability. Another distinguishing feature of trinucleotide repeat mutations is that they are dynamic, i.e., the degree of amplification increases during gametogenesis. These features, discussed in greater detail later, influence the pattern of inheritance and the phenotypic manifestations of the diseases caused by this class of mutation. To summarize, mutations can interfere with gene expression at various levels. Transcription may be suppressed by gene deletions and point mutations involving promoter sequences. Normal mRNA processing may result from mutations affecting introns or splice junctions or both. Translation is affected if a nonsense mutation creates a stop. Arglycertier glide, pro, CGT auto TCC TAT GCC CCT ASP GAC TATE, Saxallele CGT ATA TCT, or Sir XCTA TGC CCC TGAC, or low size, pro, stop. Altered reading, frame, figure 5.44, base insertion in the hexasaminidase gene, leading to a frameshift mutation. This mutation is the major cause of TAE, Sachs disease in Ashkenazi Jews. From Nussbaum Morel, et al., Thompson and Thompson Genetics and Medicine, ed. 6, Philadelphia, 2001, W.B. Saunders, p. 212, 144, Chapter 5, Genetic Disorders, codon chain termination mutation within an exon. Finally, some pathogenic point mutations may lead to expression of normal amounts of a dysfunctional protein. Against this background, we now turn our attention to the three major categories of genetic disorders. 1. Disorders related to mutant genes of large effect. 2. Diseases with multifactorial inheritance. And 3. Chromosomal disorders. To these three well-known categories must be added a heterogeneous group of single-gene disorders with non-classic patterns of inheritance. This group includes disorders resulting from triplet repeat mutations, those arising from mutations in mitochondrial DNA, mtDNA, and those in which the transmission is influenced by genomic imprinting or gonadal mosaicism. Diseases within this group are caused by mutations in single genes, but they do not follow the Mendelian pattern of inheritance. These are discussed later in this chapter. It is beyond the scope of this book to review normal human genetics. Some fundamentals of DNA structure and regulation of gene expressions were described in Chapter 1. It is important here to clarify several commonly used terms: hereditary, familial, and congenital. Hereditary disorders, by definition, are derived from one's parents and are transmitted in the germline through the generations and therefore are familial. The term congenital simply implies born with. Some congenital diseases are not genetic, for example, congenital syphilis. Not all genetic diseases are congenital. Individuals with Huntington disease, for example, begin to manifest their condition only after their 20 seconds or 30 seconds. Mendelian disorders. Virtually all Mendelian disorders are the result of mutations in single genes that have large effects. It is not necessary to detail Mendel's laws here, since every student in biology, and possibly every garden pea, has learned about them at an early age. Only some comments of medical relevance are made. It is estimated that every individual is a carrier of several deleterious genes. Most of these genes are recessive and therefore do not have serious phenotypic effects. About 80% to 85% of these mutations are familial. The remainder represent new mutations acquired de novo by an affected individual. Most mutations in autosomal genes produce partial expression in the heterozygote and full expression in the homozygote. Sickle cell anemia is caused by substitution of normal hemoglobin HbA by hemoglobin S HbS. When an individual is homozygous for the mutant gene, all the hemoglobin is of the abnormal HbS type, and even with normal saturation of oxygen, the disorder is fully expressed, i.e., sickling deformity of all red cells and hemolytic anemia. In the heterozygote, only a proportion of the hemoglobin is HbS, the remainder being HbA, and therefore red cell sickling occurs only under unusual circumstances, such as exposure to lowered oxygen tension. This is referred to as the sickle cell trait to differentiate it from full-blown sickle cell anemia. Although Mendelian traits are usually described as dominant or recessive, in some cases both of the alleles of a gene pair contribute to the phenotype, a condition called codominance. Histocompatibility and blood group antigens are good examples of codominant inheritance. A single mutant gene may lead to many end effects, termed pleiotropism. Conversely, mutations at several genetic loci may produce the same trait, genetic heterogeneity. Sickle cell anemia is an example of pleiotropism. In this hereditary disorder, not only does the point mutation in the gene give rise to HbS, which predisposes the red cells to hemolysis, but also the abnormal red cells tend to cause a logjam in small vessels, inducing, for example, splenic fibrosis, organ infarcts, and bone changes. The numerous differing end-organ derangements all are related to the primary defect in hemoglobin synthesis. On the other hand, profound childhood deafness, an apparently homogeneous clinical entity, results from many different types of autosomal recessive mutations. Recognition of genetic heterogeneity not only is important in genetic counseling but also is relevant in the understanding of the pathogenesis of some common disorders, such as diabetes mellitus. Transmission patterns of single gene disorders. Mutations involving single genes typically follow one of three patterns of inheritance: autosomal dominant, autosomal recessive, and X-linked. The general rules that govern the transmission of single gene disorders are well known. Only a few salient features are summarized. Single gene disorders with non-classic patterns of inheritance are described later. Autosomal dominant disorders are manifested in the heterozygous state, So at least one parent of an index case is usually affected. Both males and females are affected, and both can transmit the condition. When an affected person marries an unaffected one, every child has 1 chance in 2 of having the disease. In addition to these basic rules, autosomal dominant conditions are characterized by the following. With every autosomal dominant disorder, some proportion of patients do not have affected parents. Such patients owe their disorder to new mutations involving either the egg or the sperm from which they were derived. Their siblings are neither affected nor at increased risk for disease development. The proportion of patients who develop the disease as a result of a new mutation is related to the effect of the disease on reproductive capability. If a disease markedly reduces reproductive fitness, most cases would be expected to result from new mutations. Many new mutations seem to occur in germ cells of relatively older fathers. Clinical features can be modified by variations in penetrance and expressivity. Some individuals inherit the mutant gene but are phenotypically normal. This is referred to as incomplete penetrance. Penetrance is expressed in mathematical terms. Thus, 50% penetrance indicates that 50% of those who carry the gene express the trait. In contrast to penetrance, if a trait is seen in all individuals carrying the mutant gene but is expressed differently among individuals, the phenomenon is called variable expressivity. For example, manifestations of neurofibromatosis type 1 range from brownish spots on the skin to multiple skin tumors and skeletal deformities. The mechanisms underlying Mendelian disorders 145, incomplete penetrance and variable expressivity are not fully understood, but they most likely result from effects of other genes or environmental factors that modify the phenotypic expression of the mutant allele. For example, the phenotype of a patient with sickle cell anemia resulting from mutation at the beta globin locus is influenced by the genotype at the alpha globin locus because the latter influences the total amount of hemoglobin made. Chapter 14. The influence of environmental factors is exemplified by individuals heterozygous for familial hypercholesterolemia FH. The expression of the disease in the form of atherosclerosis is conditioned by the dietary intake of lipids. In many conditions, the age at onset is delayed. Symptoms and signs may not appear until adulthood, as in Huntington disease. The molecular mechanisms of autosomal dominant disorders depend on the nature of the mutation and the type of protein affected. Most mutations lead to the reduced production of a gene product or give rise to a dysfunctional or inactive protein. Whether such a mutation gives rise to dominant or recessive disease depends on whether the remaining copy of the gene is capable of compensating for the loss. Thus, understanding the reasons why particular loss of function mutations give rise to dominant versus recessive disease patterns requires an understanding of the biology. Many autosomal dominant diseases arising from deleterious mutations fall into one of a few familiar patterns. 1. Diseases involved in regulation of complex metabolic pathways that are subject to feedback inhibition. Membrane receptors such as the low-density lipoprotein LDL receptor provide one such example. In FH, discussed later, a 50% loss of LDL receptors results in a secondary elevation of cholesterol that, in turn, predisposes to atherosclerosis in affected heterozygotes. 2. Key structural proteins, such as collagen and cytoskeletal elements of the red cell membrane, for example, spectrin. The biochemical mechanisms by which a 50% reduction in the amounts of such proteins results in an abnormal phenotype are not fully understood. In some cases, especially when the gene encodes one subunit of a multimeric protein, the product of the mutant allele can interfere with the assembly of a functionally normal multimer. For example, the collagen molecule is a trimer in which the 3 collagen chains are arranged in a helical configuration. Each of the 3 collagen chains in the helix must be normal for the assembly and stability of the collagen molecule. Even with a single mutant collagen chain, normal collagen trimers cannot be formed, and hence there is a marked deficiency of collagen. In this instance, the mutant allele is called dominant negative because it impairs the function of a normal allele. This effect is illustrated by some forms of osteogenesis imperfecta, characterized by marked deficiency of collagen and severe skeletal abnormalities. Chapter 26. Less common than loss of function mutations are gain-of-function mutations, which can take 2 forms. Some mutations result in an increase in normal function of a protein. For example, excessive enzymatic activity. In other cases, mutations impart a wholly new activity completely unrelated to the affected protein's normal function. The transmission of disorders produced by gain-of-function mutations is almost always autosomal dominant, as illustrated by Huntington disease. Chapter 28. In this disease, the trinucleotide repeat mutation affecting the Huntington gene C later gives rise to an abnormal protein, called Huntingtin, that is toxic to neurons, and hence even heterozygotes develop a neurologic deficit. Table 5.1 lists common autosomal dominant disorders. Many are discussed more logically in other chapters. A few conditions not considered elsewhere are discussed later in this chapter to illustrate important principles. Autosomal recessive disorders. Autosomal recessive traits make up the largest category of Mendelian disorders. They occur when both alleles of a given gene locus are mutated. These disorders are characterized by the following features. 1. The trait does not usually affect the parents of the affected individual, but siblings may show the disease. 2 siblings have 1 chance in 4 of having the trait, i.e., the recurrence risk is 25% for each birth. And 3. If the mutant gene occurs with a low frequency in the population, there is a strong likelihood that the affected individual probing is the product of a consanguineous marriage. The following features generally apply to most autosomal recessive disorders and distinguish them from autosomal dominant diseases. The expression of the defect tends to be more uniform than in autosomal dominant disorders. Complete penetrance is common. Onset is frequently early in life. Although new mutations associated with recessive disorders do occur, they are rarely detected clinically. Since the individual with a new mutation is an asymptomatic heterozygote, several generations may pass before the descendants of such a person mate with other heterozygotes and produce affected offspring. Many of the mutated genes encode enzymes. In heterozygotes, equal amounts of normal and defective enzyme are synthesized, usually the natural margin of safety. 1. 5. Telba-dominant disorders: system disorder, nervous Huntington disease, neurofibromatosis, myotonic dystrophy, tuberous sclerosis, polycystic kidney disease, familial polyposis coli, hereditary spherocytosis, von Willebrand disease, Marfan syndromia, Ehlers-Danlos syndrome, some variants A, osteogenesis imperfecta, chondroplasia, familial hypercholesterolemia, acute intermittent porphyria, are discussed in this chapter. Other disorders listed are discussed in appropriate chapters in the book. Autosomal, urinary, gastrointestinal, hematopoietic, skeletal, metabolic. 146. Chapter 5. Genetic disorders. L5.2. Recessive disorders. System disorder. Metabolic, cystic fibrosis, phenylketonuria, galactosemia, homocystinuria, lysosomal storage disease, alpha antitrypsin deficiency, Wilson disease, hemochromatosis, glycogen storage disease, sickle cell anemia, thalassemias, congenital adrenal hyperplasia, Ehlers-Danlos syndrome, some variants A, alkaptonuria, neurogenic muscular atrophies, Friedreich ataxia, spinal muscular atrophy, discussed in this chapter. Many others are discussed elsewhere in the text. Autosomal, hematopoietic, endocrine, skeletal, nervous, ensures that cells with half the usual complement of the enzyme function normally. Autosomal recessive disorders include almost all inborn errors of metabolism. The various consequences of enzyme deficiencies are discussed later. The more common of these conditions are listed in Table 5.2. Most are presented elsewhere. A few prototypes are discussed later in this chapter. X-linked disorders. All sex-linked disorders are X-linked, and almost all are recessive. Several genes are located in the male-specific region of Y. All of these are related to spermatogenesis. Males with mutations affecting the Y-linked genes are usually infertile, and hence there is no Y-linked inheritance. As discussed later, a few additional genes with homologs on the X chromosome have been mapped to the Y chromosome, but only a few rare disorders resulting from mutations in such genes have been described. X-linked recessive inheritance accounts for a small number of well-defined clinical conditions. The Y chromosome, for the most part, is not homologous to the X chromosome, and so mutant genes on the X chromosome do not have corresponding alleles on the Y chromosome. Thus, males are said to be homozygous for X-linked mutant genes, so these disorders are expressed in males. Other features that characterize these disorders are as follows. An affected male does not transmit the disorder to his sons, but all daughters are carriers. Sons of heterozygous women have, of course, 1 chance in 2 of receiving the mutant gene. A heterozygous female usually does not express the full phenotypic change because of the paired normal allele. Because of the random inactivation of one of the X chromosomes in the female, however, females have a variable proportion of cells in which the mutant X chromosome is active. Thus, it is remotely possible for the normal allele to be inactivated in most cells, permitting full expression of heterozygous X-linked conditions in females. Much more commonly, the normal allele is inactivated in only some of the cells, and thus a heterozygous female expresses the disorder partially. An illustrative condition is glucose-6-phosphate dehydrogenase G6PD deficiency. Transmitted on the X chromosome, this enzyme deficiency, which predisposes to red cell hemolysis in patients receiving certain types of drugs, Chapter 14, is expressed principally in males. In females, a proportion of the red cells may be derived from precursors with inactivation of the normal allele. Such red cells are at the same risk for undergoing hemolysis as the red cells in homozygous males. Thus, females are not only carriers of this trait but also are susceptible to drug-induced hemolytic reactions. Because the proportion of defective red cells in heterozygous females depends on the random inactivation of one of the X chromosomes, however, the severity of the hemolytic reaction is almost always less in heterozygous women than in homozygous men. Most of the X-linked conditions listed in Table 5.3 are covered elsewhere in the text. There are only a few X-linked dominant conditions. They are caused by dominant disease-associated alleles on the X chromosome. These disorders are transmitted by an affected heterozygous female to half her sons and half her daughters, and by an affected male parent to all his daughters but none of his sons, if the female parent is unaffected. Vitamin D, resistant rickets, and Alport syndrome are examples of this type of inheritance. Key concepts: transmission patterns of single gene disorders. Autosomal dominant disorders are characterized by expression in heterozygous state. They affect males and females equally, and both sexes can transmit the disorder. Enzyme proteins are not affected in autosomal dominant disorders. Instead, receptors and structural proteins are involved. Autosomal recessive diseases occur when both copies of a gene are mutated. Enzyme proteins are frequently involved. Males and females are affected equally. X-linked disorders are transmitted by heterozygous females to their sons, who manifest the disease. Female carriers usually are protected by immune nervous discussed in this. Others are Mendelian disorders. 147. Biochemical and molecular basis of single-gene Mendelian disorders. Mendelian disorders result from alterations involving single genes. The genetic defect may lead to the formation of an abnormal protein or a reduction in the output of the gene product. Virtually any type of protein may be affected in single-gene disorders and by a variety of mechanisms. Table 5.4. To some extent, the pattern of inheritance of the disease is related to the kind of protein affected by the mutation. For this discussion, the mechanisms involved in single-gene disorders can be classified into 4 categories. 1. Enzyme defects and their consequences. 2. Defects in membrane receptors and transport systems. 3. Alterations in the structure, function, or quantity of non-enzyme proteins. And 4. Mutations resulting in unusual reactions to drugs. Enzyme defects and their consequences. Mutations may result in the synthesis of an enzyme with reduced activity or a reduced amount of a normal enzyme. In either case, the consequence is a metabolic block. Fig. 5.5 provides an example of an enzyme reaction in which the substrate is converted by intracellular enzymes, denoted as 1, 2, and 3, into an end product through intermediates 1 and 2. In this model, the final product exerts feedback control on enzyme 1, a minor pathway producing small quantities. Enzyme 1, enzyme 2, enzyme 3, substrate, intermediate 1, intermediate 2, product. Figure 5.5, a possible metabolic pathway in which a substrate is converted to an end product by a series of enzyme reactions. mTOR, products of a minor pathway. Amon and mTOR also exists. The biochemical consequences of an enzyme defect in such a reaction may lead to 3 major consequences. Accumulation of the substrate, depending on the site of block, may be accompanied by accumulation of one or both intermediates. Moreover, an increased concentration of intermediate 2 may stimulate the minor pathway in mTOR. Table 5.4 Biochemical and molecular basis of some Mendelian disorders. Protein type/function. Example: molecular lesion, enzyme phenylalanine hydroxylase splice site mutation, reduced amount hexasaminidase, a splice site mutation or frameshift mutation. Stop codon, reduced amount. Adenosine deaminase point mutations, abnormal protein with reduced activity. Enzyme inhibitor alpha antitrypsin missense mutations, impaired secretion from liver to serum. Receptor low density lipoprotein deletions, point mutations, reduction of receptor synthesis, transport to cell surface, or binding to low density lipoprotein. Vitamin D receptor point mutations, failure of normal signaling, transport. Oxygen hemoglobin deletions, reduced amount. Defective mRNA processing, reduced amount. Point mutations, abnormal structure. Ion channel cystic fibrosis deletions and other mutations. Transmembrane non-functional or misfolded proteins conductance regulator. Structural, extracellular collagen deletions or point mutations cause reduced amount of normal collagen or normal amounts of defective collagen. Fibrillin missense mutations. Cell membrane dystrophin deletion with reduced synthesis. Heterogeneous, spectrin, anchorin, or protein 4.1, factor Roman 8, hemostasis deletions, insertions, nonsense mutations, and others, reduced synthesis or abnormal factor Roman 8. Deletions heterogeneous, growth regulation RB protein, neurofibromin, disease phenylketonuria Tay-Sachs disease, severe combined, immunodeficiency, emphysema and liver disease, familial hypercholesterolemia, vitamin D, resistant rickets, alpha thalassemia, beta thalassemia, sickle cell anemia, cystic fibrosis, osteogenesis imperfecta, Ehlers-Danlos syndromes, orphan syndrome, Duchenne/Becker muscular dystrophy, hereditary spherocytosis, hemophilia A, hereditary retinoblastoma, neurofibromatosis type 1, 148 Chapter 5 Genetic disorders. Thus lead to an excess of MON and mTOR. Under these conditions, tissue injury may result if the precursor, the intermediates, or the products of alternative minor pathways are toxic in high concentrations. For example, in galactosemia, the deficiency of galactose 1-phosphate uridyltransferase Chapter 10 leads to the accumulation of galactose and consequent tissue damage. Excessive accumulation of complex substrates within the lysosomes as a result of deficiency of degradative enzymes is responsible for a group of diseases generally referred to as lysosomal storage diseases. An enzyme defect can lead to a metabolic block and a decreased amount of end product that may be necessary for normal function. For example, the deficiency of melanin may result from lack of tyrosinase, which is necessary for the biosynthesis of melanin from its precursor, tyrosine, resulting in a clinical condition called albinism. If the end product is a feedback inhibitor of the enzymes involved in the early reactions in Fig. 5.5, it is shown that the product inhibits enzyme 1. The deficiency of the end product may permit overproduction of intermediates and their catabolic products, some of which may be injurious at high concentrations. A prime example of a disease with such an underlying mechanism is Lesch-Nayan syndrome, Chapter 26. Failure to inactivate a tissue-damaging substrate is best exemplified by alpha-antitrypsin deficiency. Individuals who have an inherited deficiency of serum alpha antitrypsin are unable to inactivate neutrophil elastase in their lungs. Unchecked activity of this protease leads to destruction of elastin in the walls of lung alveoli, leading eventually to pulmonary emphysema. Chapter 15. Defects in receptors and transport systems. As we discussed in Chapter 1, biologically active substances have to be actively transported across the cell membrane. In some cases, transport is achieved by receptor-mediated endocytosis. A genetic defect in a receptor-mediated transport system is exemplified by familial hypercholesterolemia (FH), in which reduced synthesis or function of LDL receptors leads to defective transport of LDL into the cells and secondarily to excessive cholesterol synthesis by complex intermediary mechanisms. In cystic fibrosis, the transport system for chloride and bicarbonate ions in exocrine glands, sweat ducts, lungs, and pancreas is defective. By complex mechanisms not fully understood, impaired anion transport leads to serious injury to the lungs and pancreas. Chapter 10. Alterations in structure, function, or quantity of non-enzyme proteins. Genetic defects resulting in alterations of non-enzyme proteins often have widespread secondary effects, as exemplified by sickle cell disease. The hemoglobinopathies, sickle cell disease being one, all of which are characterized by defects in the structure of the globin molecule, best exemplify this category. In contrast to the hemoglobinopathies, the thalassemias result from mutations in globin genes that affect the amount of globin chain synthesized. Thalassemias are associated with reduced amounts of structurally normal alpha globin or beta globin chains. Chapter 14. Other examples of genetic disorders involving defective structural proteins include osteogenesis imperfecta, defect in collagen. Chapter 26. Hereditary spherocytosis spectrum. Chapter 14. And muscular dystrophies, dystrophin. Chapter 27. Genetically determined adverse reactions to drugs. Certain genetically determined enzyme deficiencies are unmasked only after exposure of the affected individual to certain drugs. A special area of genetics, called pharmacogenetics, is of considerable clinical importance. The classic example of drug-induced injury in a genetically susceptible individual is associated with a deficiency of the enzyme G6PD. Under normal conditions, G6PD deficiency does not result in disease, but on administration, for example, of the antimalarial drug primaquine, a severe hemolytic anemia results. Chapter 14. In recent years, an increasing number of polymorphisms of genes encoding drug-metabolizing enzymes, transporters, and receptors have been identified. In some cases, these genetic factors have a major impact on drug sensitivity and adverse reactions. It is hoped that advances in pharmacogenetics will lead to patient-tailored therapy, an example of personalized medicine. With this overview of the biochemical basis of single-gene disorders, we now consider selected examples grouped according to the underlying defect. Disorders associated with defects in structural proteins. Several diseases caused by mutations in genes that encode structural proteins are listed in Table 5.4. Many are discussed elsewhere in the text. Only Marfan syndrome and Ehlers-Danlos syndrome's EDS are discussed here because they affect connective tissue and hence involve multiple organ systems. Marfan syndrome is a disorder of connective tissues, manifested principally by changes in the skeleton, eyes, and cardiovascular system. Its prevalence is estimated to be 1 in 5,000. Approximately 70% to 85% of cases are familial and transmitted by autosomal dominant inheritance. The remainder are sporadic and arise from new mutations. Pathogenesis. Marfan syndrome results from an inherited defect in an extracellular glycoprotein called fibrillin-1. There are two fundamental mechanisms by which loss of fibrillin leads to the clinical manifestations of Marfan syndrome: loss of structural support in microfibril-rich connective tissue and excessive activation of transforming growth factor TGF-beta signaling. Each of these is discussed below. Fibrillin is the major component of microfibrils found in the extracellular matrix. Chapter 1. These fibrils provide a scaffold on which tropoelastin is deposited to form elastic fibers. Although microfibrils are widely distributed in the body, they are particularly abundant in the aorta, ligaments, and the ciliary zonules that support the lens. These tissues are prominently affected in Marfan syndrome. Fibrillin occurs in two homologous forms, fibrillin-1 and fibrillin-2, encoded by two separate genes, FB9 and FBN12, mapped on chromosomes 1521-1 and 523-31, respectively. Mutations of FB9 underlie Marfan syndrome. Mutations of the related FBN12 gene are less. Disorders 149, common, and they give rise to congenital contractural arachnodactyly, an autosomal dominant disorder characterized by skeletal abnormalities. Mutational analysis has revealed close to 1,000 distinct mutations of the FB9 gene in individuals with Marfan syndrome. Most of these are missense mutations that give rise to abnormal fibrillin-1. These can inhibit polymerization of fibrillin fibers, dominant negative effect. Alternatively, the reduction of fibrillin content below a certain threshold weakens the connective tissue haploinsufficiency. TGF-beta bioavailability. While many clinical manifestations of Marfan syndrome can be explained by changes in the mechanical properties of the extracellular matrix resulting from abnormalities of fibrillin, several others such as bone overgrowth and myxoid changes in mitral valves cannot be attributed to changes in tissue elasticity. It is now established that fibrillin 1 controls the bioavailability of TGF-beta. Reduced or altered forms of fibrillin 1 give rise to abnormal and excessive activation of TGF-beta, since normal microfibrils sequester TGF-beta. Excessive TGF-beta signaling, in turn, leads to inflammation, has deleterious effects on vascular smooth muscle development, and increases the activity of metalloproteases, causing loss of extracellular matrix. This schema is supported by two sets of observations. First, gain-of-function mutations in the TGF-beta type Roman 2 receptor give rise to a related syndrome, called Marfan syndrome type 2 MFSY. Furthermore, patients with germline mutations in one isoform of TGF-beta, called TGF-beta 3, present with an inherited predisposition to aortic aneurysm and other cardiovascular manifestations similar to those found in patients with classic Marfan syndrome. Second, angiotensin receptor Roman 2 blockers, which inhibit TGF-beta activity, markedly reduce the aortic root diameter in mouse models of Marfan syndrome. Clinical trials are underway to evaluate the efficacy of angiotensin receptor blockade in patients with Marfan syndrome. Morphology. Skeletal abnormalities are the most striking feature of Marfan syndrome. Typically, the patient is unusually tall with exceptionally long extremities and long, tapering fingers and toes. The joint ligaments in the hands and feet are lax, suggesting that the patient is double-jointed. Typically, the thumb can be hyperextended back to the wrist. The head is commonly dolichocephalic, long-headed with bossing of the frontal eminences and prominent supraorbital ridges. A variety of spinal deformities may appear, including kyphosis, scoliosis, or rotation or slipping of the dorsal or lumbar vertebrae. The chest is classically deformed, presenting either pectus excavatum, deeply depressed sternum, or a pigeon breast deformity. Ocular changes take many forms. Most characteristic is bilateral subluxation or dislocation, usually outward and upward, of the lens, referred to as ectopia lentis. This abnormality, resulting from weakening of ciliary zonules, is so uncommon in persons who do not have this disease that the finding of bilateral ectopia lentis should raise the suspicion of Marfan syndrome. Cardiovascular lesions are the most life-threatening features of this disorder. The two most common lesions are mitral valve prolapse, which occurs in 40% to 50% of cases, and, of greater importance, dilation of the ascending aorta due to cystic medial necrosis. Histologically, the changes in the media are virtually identical to those found in cystic medial necrosis not related to Marfan syndrome, Chapter 12. Loss of medial support results in progressive dilation of the aortic valve ring and the root of the aorta, giving rise to severe aortic incompetence. Weakening of the media predisposes to an intimal tear, which may initiate an intramural hematoma that cleaves the layers of the media to produce aortic dissection. After cleaving the aortic layers for considerable distances, sometimes back to the root of the aorta or down to the iliac arteries, the hemorrhage often ruptures through the aortic wall. Mendelian. Clinical features. Although mitral valve lesions are more frequent, they are clinically less important than aortic lesions. Loss of connective tissue support in the mitral valve leaflets makes them soft and billowy, creating a so-called floppy valve, Chapter 12. Valvular lesions, along with lengthening of the chordae tendineae, frequently give rise to mitral regurgitation. Similar changes may affect the tricuspid and, rarely, the aortic valve. Echocardiography greatly enhances the ability to detect the cardiovascular abnormalities and is therefore extremely valuable in the diagnosis of Marfan syndrome. The great majority of deaths are caused by rupture of aortic dissections, followed in importance by cardiac failure. While the lesions just described typify Marfan syndrome, it must be emphasized that there is great variation in the clinical expression of this genetic disorder. Patients with prominent eye or cardiovascular changes may have few skeletal abnormalities, whereas others with striking changes in body habitus have no eye changes. Although variability in clinical expression may be seen within a family, interfamilial variability is much more common and extensive. Because of such variations, the clinical diagnosis of Marfan syndrome is currently based on the so-called revised Ghent criteria. These take into account family history, cardinal clinical signs in the absence of family history, and presence or absence of fibrillin mutation. In general, major involvement of two of the four organ systems, skeletal, cardiovascular, ocular, and skin, and minor involvement of another organ is required for diagnosis. Variable expression of the Marfan defect is best explained on the basis of the many different mutations that affect the fibrillin locus, which number around 1,000. This genetic heterogeneity also poses formidable challenges in the diagnosis of Marfan syndrome. The evolving high-throughput sequencing technologies discussed later in this chapter may overcome this problem in the future. Ehlers-Danlos syndromes (EDS) comprise a clinically and genetically heterogeneous group of disorders that result from some mutations in genes that encode collagen, enzymes that modify collagen, and less commonly other proteins present in the extracellular matrix. Other disorders resulting from mutations affecting collagen synthesis include osteogenesis imperfecta, Chapter 26, Alport syndrome, Chapter 20, and epidermolysis bullosa, Chapter 25. 150, Chapter 5, Genetic disorders. Biosynthesis of collagen is a complex process, Chapter 1, that can be disturbed by genetic errors that may affect any one of the numerous structural collagen genes or enzymes necessary for post-transcriptional modifications of collagen. Hence, the mode of inheritance of EDS encompasses all three Mendelian patterns. On the basis of clinical and molecular characteristics, 6 variants of EDS have been recognized. These are listed in Table 5.5. More recently, next-generation sequencing has revealed other subgroups, bringing the total to 11 molecular types. Although individually rare, the collective frequency of EDS is 1 in 5,000 births. It is beyond the scope of this book to discuss each variant individually. Instead, the important clinical features common to most variants are summarized, and clinical manifestations are correlated with the underlying molecular defects in collagen synthesis or structure. As might be expected, tissues rich in collagen, such as skin, ligaments, and joints, are frequently involved in most variants of EDS. Because the abnormal collagen fibers lack adequate tensile strength, skin is hyperextensible, and the joints are hypermobile. These features permit grotesque contortions, such as bending the thumb backward to touch the forearm and bending the knee forward to create almost a right angle. It is believed that most contortionists have one of the EDSs. A predisposition to joint dislocation, however, is one of the prices paid for this virtuosity. The skin is extraordinarily stretchable, extremely fragile, and easily bruised. Minor injuries produce gaping defects, and surgical repair or intervention is accomplished with great difficulty because of the lack of normal tensile strength. A basic defect in connective tissue may lead to serious internal complications. These include rupture of the colon and large arteries, vascular EDS, ocular fragility with rupture of cornea and retinal detachment, kyphoscoliosis EDS, and diaphragmatic hernia, classic EDS. The biochemical and molecular basis of these abnormalities are known in all but one form of EDS, the so-called hypermobility type. Some of the EDS types are described briefly because they offer some insights into the perplexing clinical heterogeneity of these disorders. Perhaps the best characterized is the kyphoscoliosis type, the most common autosomal recessive form of EDS. It results from mutations in the PLO-DUN gene encoding lysohydroxylase, an enzyme necessary for hydroxylation of lysine residues during collagen synthesis. Affected patients have markedly reduced levels of this enzyme. Because hydroxylation is essential for intermolecular and intramolecular cross-linking of collagen fibers, a deficiency of lysohydroxylase results in the synthesis of collagen that lacks normal structural stability. The vascular type of EDS results from abnormalities of type Roman III collagen. This form is genetically heterogeneous because at least 3 distinct types of mutations affecting the COL3A gene encoding collagen type Roman III can give rise to this variant. Some affect the rate of synthesis of proalpha Roman III chains, others affect the secretion of type Roman III procollagen, and still others lead to the synthesis of structurally abnormal type Roman III collagen. Some mutant alleles behave as dominant negatives, see discussion under autosomal dominant disorders, and thus produce severe phenotypic effects. These molecular studies provide a rational basis for the pattern of transmission and clinical features that are characteristic of this variant. First, because vascular type EDS results from mutations involving a structural protein rather than an enzyme protein, an autosomal dominant pattern of inheritance would be expected. Second, because blood vessels and intestines are known to be rich in collagen type Roman III, an abnormality of this collagen is consistent with severe structural defects, for example, vulnerability to spontaneous rupture in these organs. Unlike many other EDS subtypes, the skin is not usually hyperextensible. In 2 forms of EDS, arthrochalasia type and dermatosparaxis type, the fundamental defect is in the conversion of type I procollagen to collagen. This step in collagen synthesis involves cleavage of non-collagen peptides at the N-terminus and C-terminus of the procollagen molecule. This is accomplished by N-terminal, specific, and C-terminal, specific peptidases. The defect in the conversion of procollagen to collagen in the arthrochalasia type has been traced to mutations that affect one of the 2 type I collagen genes, COLON-AN and COLON-APO. As a result, structurally abnormal proalpha or proalpha chains that resist cleavage of N-terminal peptides are formed. In patients with a single mutant allele, only 50% of the type I collagen chains are abnormal, but because these chains interfere with the formation of normal collagen helices, heterozygotes manifest the disease. In contrast, the related dermatosparaxis type is caused by mutations in the ADAMTS4 gene that encodes procollagen N peptidase, essential for the cleavage of procollagens. Because in this case the disease is caused by an enzyme deficiency, it follows an autosomal recessive form of inheritance. Finally, in the classic type of EDS, molecular analysis suggests that genes other than those that encode collagen may also be involved. In close to 90% of cases, mutations in the genes for type V collagen COL5AN and COL5APO have been detected. Surprisingly, in the remaining cases, no other collagen gene abnormalities have been found despite clinical similarity with the classic type EDS. It is suspected of Ehlers-Danlos S-table clinical findings: skin and joint hypermobility, atrophic scars, easy bruising, joint hypermobility, pain, dislocations, thin skin, arterial or uterine rupture, bruising, small joint, hyperextensibility, hypotonia, joint laxity, congenital scoliosis, ocular fragility, severe joint hypermobility, skin changes, mild, scoliosis, bruising. Severe skin fragility, cutis laxa, bruising. The EDS types were previously classified by Roman numerals. Parentheses show previous numerical equivalents. Classification. 5 syndrome. 5. EDS type of classic I/Roman. Autosomal gene defects. Mendelian disorders 151. That in some cases, genetic defects that affect the biosynthesis of other extracellular matrix molecules that influence collagen synthesis indirectly may be involved. One example is a classic EDS-like condition caused by mutation in the 10xB gene encoding tensin X, a large multimeric protein that interacts with fibrillar types I, Roman 3, and V collagens. To summarize, the common thread in EDS is some abnormality of collagen. These disorders, however, are extremely heterogeneous. At the molecular level, a variety of defects, varying from mutations involving structural genes for collagen to those involving enzymes that are responsible for post-transcriptional modifications of mRNA, have been detected. Such molecular heterogeneity results in the expression of EDS as clinically variable disorders with several patterns of inheritance. Familial hypercholesterolemia. Familial hypercholesterolemia FH is caused most commonly by mutations in the gene encoding the receptor for LDL, resulting in inadequate removal of plasma LDL by the liver. Mutations in the LDL receptor gene LDLR account for 80% to 85% of cases of FH. Much less commonly, FH is caused by mutations in two other genes involved in clearance of plasma LDL. They encode 1 apolipoprotein B100 ApoB, the ligand for LDL receptor on the LDL particle 5% to 10% cases, and 2 proprotein convertase subtilisin/kexin type 9 1% to 2% cases. This enzyme, better known by its abbreviation PCS9, reduces expression of LDL receptors by downregulating their recycling and consequent degradation in lysosomes. Each of these 3 types of mutations impairs hepatic clearance of LDL and increases serum levels of cholesterol, giving rise to premature atherosclerosis and a greatly increased risk of myocardial infarction. The functions of these genes in cholesterol metabolism are discussed below. FH caused by LDL receptor mutations is one of the most frequently occurring Mendelian disorders. Heterozygous with one mutant gene, representing about 1 in 200 individuals, have from birth a 2-fold to 3-fold elevation of plasma cholesterol level, leading to tenderness and thomas and premature atherosclerosis in adult life. Chapter 11. Homozygotes, having a double dose of the mutant gene, are much more severely affected and may have 5-fold to 6-fold elevations in plasma cholesterol levels. Skin xanthomas and coronary, cerebral, and peripheral vascular atherosclerosis may develop in these individuals at an early age. Myocardial infarction may occur before age 20 years. Large-scale studies have found that FH is present in 3% to 6% of survivors of myocardial infarction. Normal cholesterol metabolism and transport cholesterol may be derived from the diet or from endogenous synthesis. Dietary triglycerides and cholesterol are incorporated into chylomicrons in the intestinal mucosa and travel by way of the gut lymphatics to the blood. These chylomicrons are hydrolyzed by an endothelial lipoprotein lipase in the capillaries of muscle and fat. The chylomicron remnants, rich in cholesterol, are then delivered to the liver. Some of the cholesterol enters the metabolic pool to be described, and some is excreted as free cholesterol or as bile acids into the biliary tract. The endogenous synthesis of cholesterol and LDL begins in the liver. Fig. 5-6. The first step in this process is the secretion of very low-density cholesterol esters triglycerides B100. ApoC, ApoE-VLDL, fat cells. Liver cell lipolysis of VLDL, LDL receptor. Receptor-mediated clearance of IDL B100, ApoE-IDL. Receptor-mediated clearance of LDL conversion of IDL to LDL. B100 LDL, other clearance. Figure 5.6 low-density lipoprotein LDL metabolism and the role of the liver in its synthesis and clearance. Lipolysis of very low-density lipoprotein VLDL by lipoprotein lipase in the capillaries releases triglycerides, which are then stored in fat cells and used as a source of energy in skeletal muscles. ApoC, apolipoprotein C, ApoE, apolipoprotein E, B100, apolipoprotein B100 ApoB. Idle, intermediate density lipoprotein. 152 Chapter 5 Genetic Disorders. LDL receptor LDL, protein. Cholesterol esters, ApoB100. Plasma membrane, Cotran, coated PIC. Golgi apparatus, coated vesicle. PCS9, endosome. Inhibits recycling LDL receptors. Synthesis of LDL receptors. Synthesis of cholesterol. DNA HMG-CoA reductase lysosome. Receptor. RNA inhibits. Oversupply of cholesterol. Inhibits. Cholesterol. MP-cone MP-C12 amino acids. Endoplasmic reticulum. Receptor protein. Ribosome. Stimulates. Storage of cholesterol esters. Cell membrane. Steroid hormones. And bile acids. Figure 5.7 The low-density lipoprotein LDL receptor pathway and regulation of cholesterol metabolism. ApoB100. Apolipoprotein B100 ApoB. HMG-CoA. 3-hydroxy-3-methylglutaryl coenzyme A. Lipoprotein VLDL from the liver into the blood. VLDL particles are rich in triglycerides, but they contain lesser amounts of cholesterol esters. In addition, they carry apolipoproteins ApoB, ApoC, and ApoE on their surface. In the capillaries of adipose tissue and muscle, the VLDL particle undergoes lipolysis and is converted to VLDL remnant, also called intermediate density lipoprotein IDL. Compared with VLDL, IDL particles have reduced content of triglycerides and an increase in cholesterol esters. ApoC is lost, but ApoB and ApoE are retained. After release from the capillary endothelium, the IDL particles have one of two fates. Approximately 50% of newly formed IDL is rapidly taken up by the liver by receptor-mediated transport. The receptor responsible for the binding of IDL to the liver cell membrane recognizes both ApoB and ApoE. It is called ApoB/E, or more commonly the LDL receptor, because it is also involved in the hepatic clearance of LDL described later. In the liver cells, IDL is recycled to generate VLDL. The IDL particles not taken up by the liver are subjected to further metabolic processing that removes most of the remaining triglycerides in ApoE, yielding ApoB-carrying cholesterol-rich LDL particles. Although many cell types, including fibroblasts, lymphocytes, smooth muscle cells, hepatocytes, and adrenocortical cells, possess high-affinity LDL receptors, approximately 70% of the plasma LDL is cleared by the liver using a quite sophisticated transport process. Fig. 5.7. The first step involves binding of LDL to cell surface receptors, which are clustered in specialized regions of the plasma membrane called coated pits. Chapter 1. After binding, the coated pits containing the receptor-bound LDL are internalized by invagination to form coated vesicles, after which they migrate within the cell to fuse with the lysosomes. Here the LDL dissociates from the receptor, which is recycled to the surface. The recycling of LDL receptors is regulated by PCS9, which binds to LDL receptors on the surface of hepatocytes and causes their degradation after endocytosis. In the lysosomes, the LDL molecule is enzymatically degraded. The apoprotein part is hydrolyzed to amino acids, whereas the cholesterol esters are broken down to free cholesterol. This free cholesterol, in turn, crosses the lysosomal membrane to enter the cytoplasm, where it is used for membrane synthesis and as a regulator of cholesterol homeostasis. The exit of cholesterol from the lysosomes requires the action of two proteins, called MP-CoN and MP-C12C Niemann-Pick disease type C. Four separate processes are affected by the released intracellular cholesterol, as follows. See Fig. 5.7. Cholesterol suppresses cholesterol synthesis within the cell by inhibiting the activity of the enzyme 3-hydroxy-3-methylglutaryl coenzyme HMG-CoA reductase, which is the rate-limiting enzyme in the synthetic pathway. Disorders 153. Cholesterol activates the enzyme acylcoenzyme A, cholesterol acyltransferase, favoring esterification and storage of excess cholesterol. Cholesterol suppresses the synthesis of LDL receptors, thus protecting the cells from excessive accumulation of cholesterol. Cholesterol upregulates the expression of PCS9, which reduces recycling of LDL receptors and causes degradation of endocytosed LDL receptors. This provides an additional mechanism of protecting the cells from excessive accumulation of cholesterol. 1. Endoplasmic reticulum, Golgi apparatus. 2, 3, 4. LDL. As mentioned earlier, FH results from mutations in the gene encoding the receptor for LDL or the two genes that compromise its function. The impact of mutations in these genes is as follows. Mutations in LDLR gene. Heterozygotes with FH due to mutation in the LDLR gene possess only 50% of the normal number of high-affinity LDL receptors because they have only one normal gene. As a result of this defect in transport, the catabolism of LDL by the receptor-dependent pathways is impaired, and the plasma level of LDL increases 2 to 3-fold. Homozygotes have virtually no normal LDL receptors in their cells and have much higher levels of circulating LDL. In addition to defective LDL clearance, both the homozygotes and the heterozygotes have increased synthesis of LDL. The increased synthesis that contributes to hypercholesterolemia also results from a lack of LDL receptors. See Fig. 5.6. As mentioned above, IDL, the immediate precursor of plasma LDL, also uses hepatic LDL receptors ApoB/E receptors for its transport into the liver. In FH, impaired IDL transport into the liver secondarily diverts a greater proportion of plasma IDL into the precursor pool for plasma LDL. Mutations in gene encoding ApoB. Since ApoB on the surface of LDL particles is the ligand for LDL receptors, mutant ApoB reduces the binding of LDL molecules with LDL receptors. This compromise in the binding of LDL particles to its receptors increases serum LDL cholesterol, activating mutation in the PCS9 gene. This mutation greatly reduces the number of LDL receptors on the cell surface because of their increased degradation during the recycling process. The transport of LDL via the scavenger receptors seems to occur at least in part into the cells of the mononuclear phagocyte system. Monocytes and macrophages have receptors for chemically altered, for example, acetylated or oxidized LDL. Normally the amount of LDL transported along the scavenger receptor pathway is less than that mediated by the LDL receptor dependent mechanisms. In the face of hypercholesterolemia, however, There is a marked increase in the scavenger receptor, mediated traffic of LDL cholesterol into the cells of the mononuclear phagocyte system and possibly the vascular walls, Chapter 11. This increase is responsible for the appearance of xanthomas and contributes to the pathogenesis of premature atherosclerosis. The molecular genetics of FH is extremely complex. More than 2,000 mutations involving the LDL receptor gene, including DNA copy number variations, insertions, deletions, and missense and nonsense mutations, have been identified. Endosome 5. Mutation synthesis transport binding clustering recycling class I. Roman 2. Roman 3. Roman 4. VXXXXX. Figure 5.8 classification of low-density lipoprotein LDL receptor mutations based on abnormal function of the mutant protein. These mutations disrupt the receptor synthesis in the endoplasmic reticulum, transport to the Golgi complex, binding of apoprotein ligands, clustering in coated pits, and recycling in endosomes. That's shown as class VI mutation, in which initial targeting of the receptor to basolateral membrane fails to occur. Each class is heterogeneous at the DNA level, modified with permission from Hobbs H.H. et al., the LDL receptor locus and familial, hypercholesterolemia, mutational analysis of a membrane protein, and Reverend. Janet 24-13-3, 170, 1990, 1990 biannual reviews, Mendelian. These can be classified into 6 groups: Fig. 5, 8. Class I mutations are relatively uncommon and lead to a complete failure of synthesis of the LDL receptor protein null allele. Class Roman 2 mutations are fairly common. They encode LDL receptor proteins that accumulate in the endoplasmic reticulum because their folding defects make it impossible for them to be transported to the Golgi complex. Class Roman 3 mutations affect the ApoB binding site of the receptor. The mutant LDL receptors reach the cell surface but fail to bind LDL or do so poorly. Class Roman 4 mutations encode LDL receptors that are synthesized and transported to the cell surface efficiently. They bind LDL normally, but they fail to localize in coated pits, and hence the bound LDL is not internalized. Class V mutations encode LDL receptors that are expressed on the cell surface, can bind LDL, and can be internalized. However, the pH-dependent dissociation of the receptor and the bound LDL fails to occur. Such receptors are trapped in the endosome, where they are degraded, and hence they fail to recycle to the cell surface. Class VI mutations result in the failure of initial targeting of the LDL receptor to the basolateral membrane. The discovery of the critical role of LDL receptors in cholesterol homeostasis has led to the rational design of drugs that lower plasma cholesterol by increasing the number of LDL receptors. See Fig. 5.8. One strategy is coded PIT 154, Chapter 5, Genetic Disorders. Based on the ability of certain drug statins to suppress intracellular cholesterol synthesis by inhibiting the enzyme HMG-CoA reductase. The reduction in intracellular cholesterol allows greater synthesis of LDL receptors by removing the braking action of cholesterol on LDL receptor synthesis. In another strategy, antibodies that inhibit PCSK9 function reduce the degradation of LDL receptors, thereby increasing their abundance on the cell membrane and consequent increased clearance of LDL cholesterol from the blood. These agents have profound cholesterol-lowering effects, and large clinical trials have shown the benefits of using this class of drugs in the treatment of patients who do not respond adequately to statins alone. Interestingly, PCSK9 was discovered accidentally in individuals with exceedingly low serum cholesterol who were found to have loss of function variants of the PCSK9 gene. Rough endoplasmic reticulum, lysosomal enzyme protein, mannose-6-phosphate, receptor, mannose-6-phosphate, Golgi apparatus. Key concepts: familial hypercholesterolemia. FH is an autosomal dominant disorder caused by mutations in the genes encoding the 1 LDL receptor 85% cases, 2 ApoB protein 5% to 10% cases, or 3 activating mutations of PCSK9 1% to 2% cases. Patients develop hypercholesterolemia as a consequence of impaired transport of LDL into the cells. In heterozygotes from mutations in the LDLR gene, elevated serum cholesterol greatly increases the risk of atherosclerosis and result in coronary artery disease. Homozygotes have an even greater increase in serum cholesterol and a higher frequency of ischemic heart disease. Cholesterol also deposits along tendon sheaths to produce xanthomas, mitochondria, autophagy, lysosomal enzyme, lysosome, phagocytosis, heterophagy. Disorders associated with enzyme defects. Lysosomal storage diseases. Lysosomes are key components of the intracellular digestive system. They contain a battery of hydrolytic enzymes, which have 2 special properties. First, they function in the acidic milieu of the lysosomes. Second, these enzymes constitute a special category of secretory proteins that are destined not for the extracellular fluids but for intracellular organelles. This latter characteristic requires special processing within the Golgi apparatus, which merits brief discussion. Similar to all other secretory proteins, lysosomal enzymes or acid hydrolases, as they are sometimes called, are synthesized in the endoplasmic reticulum and transported to the Golgi apparatus. Within the Golgi complex, they undergo a variety of post-translational modifications, including the attachment of terminal mannose 6-phosphate groups to some of the oligosaccharide side chains. Phosphorylated mannose residues serve as an address label that is recognized by specific receptors found on the inner surface of the Golgi membrane. Lysosomal enzymes bind these receptors and are thereby segregated from the numerous other secretory proteins within the Golgi. Subsequently, small transport vesicles containing the receptor-bound enzymes are pinched off from the Golgi and proceed to fuse with the lysosomes. Thus, the enzymes are targeted to their intracellular abode, and the vesicles are shuttled back to Figure 5.9 synthesis and intracellular transport of lysosomal enzymes. The Golgi Fig. 5.9. As indicated later, genetically determined errors in this remarkable sorting mechanism may give rise to one form of lysosomal storage disease. Recent studies have established a close link between lysosomal storage diseases and several neurodegenerative disorders. The cellular and molecular mechanisms of this linkage will be discussed below. The lysosomal enzymes catalyze the breakdown of a variety of complex macromolecules. These large molecules may be derived from the metabolic turnover of intracellular organelles autophagy, or they may be acquired from outside the cells by phagocytosis heterophagy. An inherited deficiency of a functional lysosomal enzyme gives rise to two pathologic consequences. Fig. 5.10. Catabolism of the substrate of the missing enzyme remains incomplete, leading to the accumulation of the partially degraded insoluble metabolite within the lysosomes. This is called primary accumulation. Stuffed with incompletely digested macromolecules, lysosomes become large and numerous enough to interfere with normal cell functions. Mendelian disorders 155. Normal lysosomal degradation. ABC. Complex substrate. Small diffusible end products. Primary storage. Defective fusion of autophagosome with lysosome. Effective degradation of intracellular organelles. Accumulation of aberrant mitochondria. Accumulation of toxic proteins. Secondary storage. Induction of cell damage. Generation of free radicals. Cell death. Figure 5.10. Pathogenesis of lysosomal storage diseases. In the example shown, a complex substrate is normally degraded by a series of lysosomal enzymes A, B, and C into soluble end products. If there is a deficiency or malfunction of one of the enzymes, for example, B, catabolism is incomplete, and insoluble intermediates accumulate in the lysosomes. In addition to this primary storage, secondary storage and toxic effects result from defective autophagy. There is a tight linkage between autophagy, mitochondrial functions, and lysosomes. As discussed in Chapter 2, the diverse range of cellular organelles and molecules are degraded by autophagy, including complex lipids, polyubiquitinated proteins, mitochondria, and fragments of the endoplasmic reticulum. In particular, autophagy is essential for turnover of mitochondria by a process termed mitophagy. This serves as a quality control system whereby dysfunctional mitochondria are degraded. Because of the accumulation of undigested macromolecules in the lysosomes, the rate at which lysosomes process organelles delivered by autophagocytic vacuoles is markedly reduced. This leads to persistence of dysfunctional and leaky mitochondria with poor calcium buffering capacity and altered membrane potentials in lysosomal enzyme deficiency AB. Stored non-metabolized products. The lysosomes. Damaged mitochondria generate free radicals and release molecules that trigger the intrinsic pathway of apoptosis. Impaired autophagy gives rise to secondary accumulation of autophagic substrates, including ubiquitinated and aggregate-prone polypeptides, such as alpha-synuclein and Huntington protein. This provides a molecular link between neurodegenerative disorders and lysosomal storage diseases, such as Gaucher disease discussed below. There are three general approaches to the treatment of lysosomal storage diseases. The most obvious is enzyme replacement therapy, currently in use for several of these diseases. Another approach, substrate reduction therapy, is based on the premise that if the substrate to be degraded by the lysosomal enzyme can be reduced, the residual enzyme activity may be sufficient to catabolize it and prevent accumulation. A more recent strategy is based on the understanding of the molecular basis of enzyme deficiency. In many disorders, exemplified by Gaucher disease, the enzyme activity is low because the mutant proteins are unstable and prone to misfolding and hence degraded in the endoplasmic reticulum. In such diseases, an exogenous competitive inhibitor of the enzyme can, paradoxically, bind to the mutant enzyme and act as the folding template that assists proper folding of the enzyme and thus prevents its degradation. Such molecular chaperone therapy is under active investigation. In addition to the aforementioned, hematopoietic stem cell transplants and gene therapy are also being evaluated in specific cases. Although the combined frequency of lysosomal storage disorders is about 1 in 5,000 live births, lysosomal dysfunction may be involved in the etiology of several more common diseases. For example, an important genetic risk factor for developing Parkinson's disease is the carrier state for Gaucher disease, and virtually all patients with Gaucher disease develop Parkinson's disease. Niemann-Pick type C disease is another lysosomal storage disorder that increases the risk for Alzheimer's disease. Such interconnectedness stems from the multifunctionality of the lysosome. For example, lysosomes play critical roles in 1. Autophagy, resulting from fusion with the autophagosome, 2. Immunity, because they fuse with phagosomes, and 3. Membrane repair, through fusion with the plasma membrane. Approximately 70 lysosomal storage diseases have been identified. These may result from abnormalities of lysosomal enzymes or proteins involved in substrate degradation, endosomal sorting, or lysosomal membrane integrity. Lysosomal storage disorders are divided into categories based on the biochemical nature of the substrates and the accumulated metabolites, Table 5.6. Within each group are several entities, each resulting from the deficiency of a specific enzyme. In general, the distribution of the stored material, and hence the organs affected, is determined by two interrelated factors. One, the tissue where most of the material to be degraded is found, and two, the location where most of the degradation normally occurs. For example, the brain is rich in gangliosides, and hence defective hydrolysis of gangliosides, as occurs in G-MON and G-MPRO gangliosidosis, results primarily in accumulation within neurons and consequent neurologic symptoms. Defects in degradation of mucopolysaccharides affect virtually every organ because mucopolysaccharides are 156. Chapter 5, Genetic Disorders. Table 5.6. Disease. Glycogenosis. Sphingolipidosis. G-MON gangliosidosis type 1. Infantile. Generalized type 2. Juvenile. G-MPRO gangliosidosis. Tay-Sachs disease. Sanoff disease. G-MPRO gangliosidosis variant AB. Sulfatidosis. Metachromatic leukodystrophy. Multiple sulfatase deficiency. Storage disease. Crab disease. Fabry disease. Gaucher disease. Niemann-Pick disease. Types A and B. Mucopolysaccharidosis. MPSS. MPS IH Hurler. MPS Roman 200. Mucolipidosis. MLSI cell disease. ML Roman 2. Metacidosis. Other lysosomal storage. Enzyme deficiency type 2. Pompe disease. Alpha 14. D. Alpha. Deficiency of alpha. Galactose. Sparta 2. Less widely distributed in the body, because cells of the mononuclear phagocyte system are especially rich in lysosomes and are involved in the degradation of a variety of substrates. Organs rich in phagocytic cells, such as the spleen and liver, are frequently enlarged in several forms of lysosomal storage disorders. The ever-expanding number of lysosomal storage diseases can be divided into rational categories based on the biochemical nature of the accumulated metabolite, thus creating such subgroups as glycogenosis, sphingolipidosis, lipidosis, mucopolysaccharidosis, MPSS, and mucolipidosis. See Table 5.6. Most of these conditions are very rare, and their detailed description is better relegated to specialized texts and reviews. Only a few of the more common conditions are considered here. Tay-Sachs disease. G-MPRO gangliosidosis. Hexasaminidase alpha subunit deficiency. G-MPRO gangliosidosis are a group of 3 lysosomal storage diseases caused by deficiency of the enzyme beta-hexasaminidase, resulting in an inability to catabolize G-MPRO gangliosides. There are 2 isoenzymes of beta-hexasaminidase, Hex A, consisting of 2 subunits, alpha and beta, and Hex B, a homodimer of beta subunits. Degradation of G-MPRO gangliosides requires 3 polypeptides encoded by 3 distinct genes. Hexa on chromosome 15, which encodes the alpha subunit of Hex A. Hexa on chromosome 5, which encodes the beta subunit of Hexa and Hex B. And G-MPRO on chromosome 5, which encodes the activator of hexasaminidase. The phenotypic effects of mutations affecting these genes are fairly similar because they result from accumulation of G-MPRO gangliosides. The underlying enzyme defect, however, is different for each. Tay-Sachs disease, the most common form of G-MPRO gangliosidosis, results from mutations in the alpha subunit locus on chromosome 15 that cause a severe deficiency of hexasaminidase A. This disease is especially prevalent among Jews, particularly among those of Eastern European Ashkenazic origin, in whom a carrier rate of 1 in 30 has been reported. The molecular basis for neuronal injury resulting from hexasaminidase deficiency is not fully understood. More than 100 mutations have been described in the hexa. Disorders 157, alpha subunit gene. Most affect protein folding. Because the mutant protein is misfolded, it induces the so-called unfolded protein response. Chapter 2. If such misfolded enzymes are not stabilized by chaperones, they undergo proteasomal degradation, leading to accumulation of toxic substrates and intermediates within neurons. These findings have spurred clinical trials of molecular chaperone therapy for some variants of later onset Tay-Sachs and other selected lysosomal storage diseases. Such therapy involves the use of synthetic chaperones that can cross the blood-brain barrier, bind to the mutated protein, and enable its proper folding. Sufficient functional enzyme can then be rescued to ameliorate the effects of the inborn error. Morphology. Hexasaminidase is absent from virtually all the tissues, so G-MPRO ganglioside accumulates in many tissues, for example, heart, liver, spleen, nervous system, but the involvement of neurons in the central and autonomic nervous systems and retina dominates the clinical picture. On histologic examination, the neurons are ballooned with cytoplasmic vacuoles, each representing a markedly distended lysosome filled with gangliosides Fig. 5. 11. With the electron microscope, several types of cytoplasmic inclusions can be visualized, the most prominent being wall Configurations within lysosomes composed of onion skin layers of membranes Fig. 5, 11b. In time there is progressive destruction of neurons, proliferation of microglia, and accumulation of complex lipids and phagocytes within the brain substance. The ganglion cells in the retina are similarly swollen with GM12 ganglioside, particularly at the margins of the macula. A cherry red spot thus appears in the macula, representing accentuation of the normal color of the macular choroid contrasted with the pallor produced by swollen ganglion cells in the remainder of the retina. Chapter 29. This finding is characteristic of Tay-Sachs disease and other storage disorders affecting the neurons. Mendelian. Clinical features affected infants appear normal at birth but begin to manifest signs and symptoms at about age 6 months. There is relentless motor and mental deterioration, resulting in motor incoordination and intellectual disability, leading eventually to muscular flaccidity, blindness, and increasing dementia. Sometime during the early course of the disease, the characteristic, but not pathognomonic, cherry red spot appears in the macula of the eye in almost all patients. Over the span of 1 or 2 years, a complete vegetative state is reached, followed by death at age 2 to 3 years. Antenatal diagnosis and carrier detection are possible by enzyme assays and DNA-based analysis. Niemann-Pick disease types A and B. Niemann-Pick disease types A and B are two related disorders that are characterized by lysosomal accumulation of sphingomyelin due to an inherited deficiency of sphingomyelinase. Type A is a severe infantile form with extensive neurologic involvement, marked visceral accumulations of sphingomyelin, and progressive wasting and early death within the first 3 years of life. In contrast, patients with type B disease have organomegaly but generally no central nervous system involvement. Patients usually survive into adulthood. As with Tay-Sachs disease, Niemann-Pick disease types A and B are common in Ashkenazi Jews. The gene for acid sphingomyelinase maps to chromosome 1115-4 and is one of the imprinted genes that is preferentially expressed from the maternal chromosome as a result of epigenetic silencing of the paternal gene discussed later. Although this disease is typically inherited as an autosomal recessive, heterozygotes who inherit the mutant allele from the mother can develop Niemann-Pick disease. More than 180 mutations have been found in the acid sphingomyelinase gene, and there seems to be a correlation between the type of mutation, the severity of enzyme deficiency, and the phenotype. B. Figure 5.11 Ganglion cells in Tay-Sachs disease. Under the light microscope, a large neuron has obvious lipid vacuolation. B. A portion of a neuron under the electron microscope shows prominent lysosomes with whorled configurations. Part of the nucleus is shown above. A. Courtesy Dr. Arthur Weinberg, Department of Pathology, University of Texas Southwestern Medical Center, Dallas, Texas. B. Courtesy Dr. Joe Rutledge, University of Texas Southwestern Medical Center, Dallas, Texas. Chapter 5 Genetic Disorders. Morphology. In the classic infantile type of variant, a missense mutation causes almost complete deficiency of sphingomyelinase. Sphingomyelin is a ubiquitous component of cellular including organular membranes, and so the enzyme deficiency blocks degradation of the lipid, resulting in its progressive accumulation within lysosomes, particularly within cells of the mononuclear phagocyte system. Affected cells become enlarged, sometimes to 90 μm in diameter, due to the distension of lysosomes with sphingomyelin and cholesterol. Innumerable small vacuoles of relatively uniform size are created, imparting foaminess to the cytoplasm. Fig. 5.12. Electron microscopy confirms that the vacuoles are engorged secondary lysosomes that often contain membranous cytoplasmic bodies resembling concentric lamelated myelin figures, sometimes called zebra bodies. The lipid-laden phagocytic foam cells are widely distributed in the spleen, liver, lymph nodes, bone marrow, tonsils, gastric, intestinal tract, and lungs. The involvement of the spleen generally produces massive enlargement, sometimes to 10 times its normal weight, but the hepatomegaly is usually not quite so striking. The lymph nodes are generally moderately to markedly enlarged throughout the body. The neuronal involvement is diffuse, affecting all parts of the nervous system. Vacuolation and ballooning of neurons constitute the dominant histologic change, which in time leads to cell death and loss of brain substance. A retinal cherry red spot similar to that seen in Tay-Sachs disease is present in about 1/3 to 1/2 of affected individuals. Clinical manifestations and type of disease may be present at birth and almost invariably become evident by age 6 months. Infants typically have a protuberant abdomen because of hepatosplenomegaly. Once the manifestations appear, they are followed by progressive failure to thrive, vomiting, fever, and generalized lymphadenopathy, as well as progressive deterioration of psychomotor function. Death occurs usually within the first or second year of life. 158. Figure 5.12 Niemann-Pick disease in liver. The hepatocytes and Kupffer cells have a foamy, vacuolated appearance due to deposition of lipids. Courtesy Dr. Arthur Weinberg, Department of Pathology, University of Texas Southwestern Medical Center, Dallas, Texas. The diagnosis is established by biochemical assays for sphingomyelinase activity in leukocytes or bone marrow biopsy. Individuals affected with types A and B as well as carriers can be detected by DNA analysis. Niemann-Pick disease type C, although previously considered to be related to types A and B, Niemann-Pick disease type C is distinct at the biochemical and genetic levels and is more common than types A and B combined. Mutations in two related genes, NP-cone and NP-C12, can give rise to Niemann-Pick disease type C, with NP-cone being responsible for 95% of cases. Unlike most other storage diseases, Niemann-Pick disease type C is due to a primary defect in non-enzymatic lipid transport. NP-cone is membrane-bound, whereas NP-C12 is soluble. Both are involved in the transport of free cholesterol from the lysosomes to the cytoplasm. Niemann-Pick disease type C is clinically heterogeneous. It may present as hydrops fetalis in stillbirth, as neonatal hepatitis, or, most commonly, as a chronic form characterized by progressive neurologic damage. The clinical course is marked by ataxia, vertical supranuclear gaze palsy, dystonia, dysarthria, and psychomotor regression. Gaucher disease. Gaucher disease refers to a cluster of autosomal recessive disorders resulting from mutations in the gene encoding glucose ribosydase. It is the most common lysosomal storage disorder. The affected gene encodes glucose ribosydase, an enzyme that normally cleaves the glucose residue from ceramide. As a result of the enzyme defect, glucose ribosides accumulate principally in phagocytes but in some subtypes also in the central nervous system. Glucose ribosides are continually formed from the catabolism of glycolipids derived mainly from the cell membranes of senescent leukocytes and red cells. It is clear now that the pathologic changes in Gaucher disease are caused not just by the burden of storage material but also by activation of macrophages and the consequent secretion of cytokines such as interleukin IL-1, IL-6, and tumor necrosis factor TNF. Three clinical subtypes of Gaucher disease have been distinguished. The most common, accounting for 99% of cases, is type I, or the chronic non-neuronopathic form. In this type, storage of glucose ribosides is limited to the mononuclear phagocytes throughout the body without involving the brain. Splenic and skeletal involvements dominate this pattern of the disease. It is found principally in Jews of European stock. Individuals with this disorder have reduced but detectable levels of glucose ribosydase activity. Longevity is shortened, but not markedly. Type Roman II, or acute neuronopathic Gaucher disease, is the infantile acute cerebral pattern. This form has no predilection for Jews. In these patients, there is virtually no detectable glucose ribosydase activity in the tissues. Hepatosplenomegaly is also seen in this form of Gaucher disease, but the clinical picture is dominated by progressive central nervous system involvement leading to death at an early age. The third pattern, type Roman III, is intermediate between types I and Roman II. These patients have the systemic involvement characteristic of type I but have progressive central. Disorders 159, nervous system disease that usually begins in adolescence or early adulthood. Morphology. Glucose ribosides accumulate in massive amounts within phagocytic cells throughout the body in all forms of Gaucher disease. The distended phagocytic cells, known as Gaucher cells, are found in the spleen, liver, bone marrow, lymph nodes, tonsils, thymus, and Peyer's patches. Similar cells may be found in both the alveolar septum and the air spaces in the lung. In contrast to other lipid storage diseases, Gaucher cells rarely appear vacuolated, but instead have a fibrillary type of cytoplasm likened to crumpled tissue paper Fig. 5.13. Gaucher cells are often enlarged, sometimes up to 100 μm in diameter, and have one or more dark, eccentrically placed nuclei. Periodic acid. Skiff staining is usually intensely positive. With the electron microscope, the fibrillary cytoplasm can be resolved as elongated, distended lysosomes containing the stored lipid in stacks of bilayers. Figure 5.13 Gaucher disease involving the bone marrow. A. B. Gaucher cells are plump macrophages that characteristically have the appearance in the cytoplasm of crumpled tissue paper due to accumulation of glucose riboside. Right stain. B. Hematoxylin and eosin. Courtesy Dr. John Anastasi, Department of Pathology, University of Chicago, Ill. In type I disease, the spleen is enlarged, sometimes up to 10 kg. The lymphadenopathy is mild to moderate and is body-wide. Accumulation of Gaucher cells in the bone marrow occurs in 70% to 100% of cases of type I Gaucher disease. It produces areas of bone erosion that are sometimes small but, in other cases, sufficiently large to give rise to pathologic fractures. Bone destruction occurs due to the secretion of cytokines by activated macrophages. In patients with cerebral involvement, Gaucher cells are seen in the virtual Robbins spaces, and arterioles are surrounded by swollen adventitial cells. There is no storage of lipids in the neurons, yet neurons appear shriveled and are progressively destroyed. It is suspected that the lipids that accumulate in the phagocytic cells around blood vessels secrete cytokines that damage nearby neurons. Mendelian mutation of the glucose ribosydase gene is the most common known genetic risk factor for development of Parkinson's disease. Patients with Gaucher disease have a 20-fold higher risk of developing Parkinson's disease compared with controls, and 5% to 10% of patients with Parkinson's disease have mutations in the gene encoding glucose ribosydase. There is a reciprocal relationship between the level of this enzyme and aggregation of alpha-synuclein, the protein involved in the pathogenesis of Parkinson's disease, Chapter 24. As discussed earlier, patients with lysosomal diseases have impairment in autophagy, which allows aggregation and persistence of proteins like alpha-synuclein. The level of glucose riboside and leukocytes or cultured fibroblasts is helpful in diagnosis and in the detection of heterozygote carriers. DNA testing is also available in select populations. Clinical features. The course of Gaucher disease depends on the clinical subtype. In type I, symptoms and signs first appear in adult life and are related to splenomegaly or bone involvement. Most commonly there is pancytopenia or thrombocytopenia secondary to hypersplenism. Pathologic fractures and bone pain occur if there has been extensive expansion of the marrow space. Although the disease is progressive in adults, it is compatible with long life. In types Roman II and Roman III, central nervous system dysfunction, convulsions, and progressive mental deterioration dominate, although organs such as the liver, spleen, and lymph nodes are also affected. The diagnosis in homozygotes can be made by measurement of glucose riboside activity in peripheral blood leukocytes or in extracts of cultured skin fibroblasts. The enzyme assay cannot identify heterozygotes because the levels of glucose riboside are difficult to distinguish from those in normal cells. In principle, heterozygotes can be identified by detection of mutations. However, because more than 150 mutations in the glucose riboside gene can cause Gaucher disease, currently it is not possible to use a single genetic test. However, when the causative mutation in a patient is known, the heterozygote can be identified with molecular tests. The landscape of genetic testing is rapidly changing with the application of next-generation sequencing. Replacement therapy with recombinant enzymes is the mainstay for treatment of Gaucher disease. It is effective in 160 Chapter 5 genetic disorders. Those with type I disease can expect normal life expectancy. However, such therapy is extremely expensive because the fundamental defect resides in mononuclear phagocytic cells originating from marrow stem cells. Allogeneic hematopoietic stem cell transplantation can be curative. Other work is directed toward correction of the enzyme defect by transfer of the normal glucose riboside gene into the patient's hematopoietic stem cells. Substrate reduction therapy with inhibitors of glucosylceramide synthetase is also being evaluated. Mucopolysaccharidosis. MPSs are a group of closely related syndromes that result from genetically determined deficiencies of enzymes involved in the degradation of mucopolysaccharides glycosaminoglycans. Chemically, mucopolysaccharides are long-chain complex carbohydrates that are linked with proteins to form protoglycans. They are abundant in extracellular matrix, joint fluid, and connective tissue. The glycosaminoglycans that accumulate in MPSs are dermatan sulfate, heparan sulfate, keratin sulfate, and chondroitin sulfate. 11 enzymes involved in the degradation of these molecules cleave terminal sugars from the polysaccharide chains disposed along a polypeptide or core protein. In the absence of enzymes, these chains accumulate within lysosomes in various tissues and organs of the body. There are 11 clinical variants of MPS, each resulting from the deficiency of one specific enzyme. Some variants have subvariants. All the MPSs except one are inherited as autosomal recessive traits. The exception, Hunter syndrome, is an X-linked recessive trait. Within a given group, for example, MPSI, characterized by a deficiency of alpha-L-iduronidase, subgroups exist that result from different mutant alleles at the same genetic locus. Thus, the severity of enzyme deficiency and the clinical picture even within subgroups are often different. In general, MPSs are progressive disorders, characterized by coarse facial features, clouding of the cornea, joint stiffness, and intellectual disability. Urinary excretion of the accumulated mucopolysaccharides is often increased and is used as a diagnostic tool. Morphology. The accumulated mucopolysaccharides are generally found in mononuclear phagocytic cells, endothelial cells, intimal smooth muscle cells, and fibroblasts throughout the body. Common sites of involvement are thus the spleen, liver, bone marrow, lymph nodes, blood vessels, and heart. Microscopically, affected cells are distended and have apparent clearing of the cytoplasm to create so-called balloon cells. Under the electron microscope, the clear cytoplasm can be resolved as numerous minute vacuoles. These are swollen lysosomes containing a finely granular periodic acid, SCIF, positive material that can be identified biochemically as mucopolysaccharide. Similar lysosomal changes are found in the neurons of those syndromes characterized by central nervous system involvement. In addition, however, some of the lysosomes in neurons are replaced by lamellated zebra bodies similar to those seen in Niemann-Pick disease. Hepatosplenomegaly, skeletal deformities, valvular lesions, and subendothelial arterial deposits, particularly in the coronary arteries, and lesions in the brain are common threads that run through all the MPSs. In many of the more protracted syndromes, coronary subendothelial lesions lead to myocardial ischemia. Thus, myocardial infarction and cardiac decompensation are important causes of death. Clinical features of the 11 recognized variants, only 2 well-characterized syndromes are described briefly here. Hurler syndrome, also called MPSIH, results from a deficiency of alpha-L-iduronidase. It is one of the most severe forms of MPS. Affected children appear normal at birth but develop hepatosplenomegaly by age 6 to 24 months. Their growth is retarded, and, as in other forms of MPS, they develop coarse facial features and skeletal deformities. Death occurs by age 6 to 10 years and is often due to cardiovascular complications. Hunter syndrome, also called MPS Roman II, differs from Hurler syndrome in mode of inheritance, X-linked, absence of corneal clouding, and milder clinical course. AY concepts lysosomal storage diseases, inherited mutations leading to defective lysosomal enzyme functions gives rise to accumulation and storage of complex substrates in the lysosomes and defects in autophagy resulting in cellular injury. Tay-Sachs disease is caused by an inability to metabolize GM12 gangliosides due to lack of the alpha subunit of lysosomal hexasaminidase. GM12 gangliosides accumulate in the central nervous system and cause severe intellectual disability, blindness, motor weakness, and death by 2 to 3 years of age. Niemann-Pick disease types A and B are caused by a deficiency of sphingomyelinase. In the more severe type of variant, accumulation of sphingomyelin in the nervous system results in neuronal damage. Lipid also is stored in phagocytes within the liver, spleen, bone marrow, and lymph nodes, causing their enlargement. In type B, neuronal damage is not present. Niemann-Pick disease type C is caused by a defect in cholesterol transport and resultant accumulation of cholesterol and gangliosides in the nervous system. Affected children most commonly exhibit ataxia, dysarthria, and psychomotor regression. Gaucher disease results from lack of the lysosomal enzyme glucocerebrosidase and accumulation of glucocerebroside in mononuclear phagocytic cells. In the most common, type I variant, affected phagocytes become enlarged Gaucher cells and accumulate in liver, spleen, and bone marrow, causing hepatosplenomegaly and bone erosion. Types Roman II and Roman III are characterized by variable neuronal involvement. Gaucher disease has a strong association with Parkinson's disease. MPSs result in accumulation of mucopolysaccharides in many tissues including liver, spleen, heart, blood vessels, brain, cornea, and joints. Affected patients in all forms have coarse facial features. Manifestations of Hurler syndrome include corneal clouding, coronary arterial and valvular deposits, and death in childhood. Hunter syndrome is associated with a milder clinical course.